Please.
Good evening, everyone, and thank you, Councillor Hill, for my introduction. So I'm Dr. Anna Sen, a public health physician for Public Health Northamptonshire. Vicky and the team, they asked me if I can just answer a few of the questions on vaccinations. So I offered myself. Before I answer the questions, I'll probably behave like a primary school teacher and take you through some of the stuff on vaccination, which probably may answer some of your questions already. So if I start, so all of you probably know, I'm just adding it, what is a virus? So as we all know, virus is just an infective agent made up of protein and can only multiply in a living cell or a host. Again, now the question arises, what is COVID-19 virus? So it is from a coronavirus family, which is a very common virus. This is a common cold virus. So we get illnesses with coronavirus like common cold and the serious illness you must have heard about SARS. And this virus, particularly this COVID-19, has been named SARS coronavirus 2 virus, and this is an RNA virus. Now, the importance of vaccine. So this COVID, as we all know, causes so many complications. The most important is a respiratory complication, which causes pneumonia. That leads to septicemia and then renal failure. People land up in hospital, in ITU, and then leads to mortality in highly vulnerable people. So that is why how can we obtain immunity? Either through infection or the vaccine. So what is vaccine and how does it work? The vaccination is a simple, safe, and effective way of protecting people against harmful diseases, and COVID is one of them. It uses our body's natural defenses to build resistance to specific infections and makes our immune system stronger by training our immune system to create antibodies. Vaccine, again, only contains either killed or very weakened form of the organisms. They do not cause the disease or put us at risk of its complications. So that myth that vaccine may give us coronavirus or a COVID infection is a myth. It doesn't give us the illness. Vaccine recognizes invading organisms, produces antibodies, and remembers the disease or the disease pattern and how to fight that disease, and then quickly destroys the organisms before the organism can cause complication within us. So these are the benefit of vaccination. That is why we all should, whosoever are offered vaccination, should take vaccinations. Now, how do vaccines protect individuals? So when a person gets vaccinated against a disease, their risk of infection is reduced. They are less likely to transmit the virus. And as more people in a community get vaccinated, fewer people remain vulnerable, and there is less possibility for organism to infect those non-vaccinated people, vulnerable people. It lowers the possibility for organisms to circulate in the community. So it prevents community transmission, which is currently happening with the COVID. It protects those who cannot be vaccinated due to health conditions like severe allergies, anaphylaxis. And in the scenario for COVID, we do not have adequate data for vaccinating pregnant women, so they cannot be vaccinated, and children. So most of the population, if get vaccinated, it will protect those women and children as well. Herd immunity, we all must have heard about it. We also call it population immunity. This is the indirect protection from an infectious disease that happens when immunity develops in a population, either through vaccination or through previous infection. Just because in the COVID, we haven't yet obtained adequate herd immunity. So that is why vaccination is very important to get the required percentage of herd immunity to prevent further spread of the virus. In communities with high herd immunity, the non-immune people have a lower risk of disease than they otherwise would. So these are the benefits and how we protect our communities and the people. Why should we get vaccinated? Just two bullet points: to protect ourselves and to protect those around us. So it's not just ourselves, it is to protect others as well. How vaccines are developed, we may be asking, and we have so many myths going around. So first of all, what happens, an experimental vaccine is first tested on animals. It doesn't go straight away on human beings. So it is first tested on animals to evaluate its safety and potential to prevent disease. If we succeed there, then it is tested in human clinical trials. And human clinical trials are in 3 phases. Phase 1, we assess the safety. We confirm whether it generates an immune response, and then we determine the right doses required to generate that immune response. Phase 2, it will closely monitor for any side effects. So phase 2 is for monitoring side effects and efficacy of the vaccine. And phase 3 is to assess the safety and efficacy, and we compare with others. So it's a control and the individuals who are being vaccinated. So it's a comparative study, phase 3. So now COVID-19 vaccines. There are 4 main types of COVID-19 vaccines. Sorry, I'm like taking a class for you all, but that will help you all to answer, and I'll share that. So there are 4 types of COVID-19 vaccines. One is called viral vector vaccine. So you'll ask me, what is it, Anna? So it is generally altered common cold virus called adenovirus, which carry the genetic instructions used to create spike protein, which is the coronavirus has a spikes on its surface. So it is spike proteins, or the crowns in a lay language. AstraZeneca vaccine, which we are using, is a viral vector vaccine. The other is mRNA vaccine, which works incredibly similar to viral vector vaccine. Both of them, even the mRNA, we all probably know, we have read in our science classes in the schools that we have DNA, and mRNA is a single strand of DNA. So the mRNA vaccine, again, it produces in the body the coronavirus spikes. So Pfizer and Moderna are mRNA vaccines. Third type of vaccine, which we do not have it here, is called protein adjuvant vaccine. It teaches, so this type of vaccine teaches our immune system to recognize a foreign body, which is a SARS coronavirus 2 protein spikes. And this vaccine directly inserts protein spikes into the body. The other 2 vaccines which I have discussed, the spike protein is developed within the body after the vaccination. In this one, we are inserting the spike protein into the body. Now, fourth one is like flu vaccine, inactivated whole virus vaccines. This vaccine insert a dead or inactive version of SARS coronavirus 2 virus into the body, and then it triggers the immune response. So currently in the country, we are using Pfizer, Moderna, Oxford University, which is AstraZeneca, and they are approved for use by MHRA, and we are using that. Another vaccine this time, which is manufactured by Novavax, has shown promising efficacy data and has been shown to be 89.3% effective. Pfizer is 94% effective, and especially it is more effective in over 65. The Oxford University and AstraZeneca is, again, it is 90% effective. And then Moderna has the maximum effectiveness, which is 95% effective, but this is not yet available to us. It will be available to us after spring, sometimes in May. Other vaccines which are available is called Valneva, which is an inactive whole virus. Novavax, still not approved by our MHRA. And then third one is Janssen, which is Johnson and Johnson vaccine, which is again a viral vector. This is just for your information if somebody, asks or if you come across something. And the fourth one is the Sputnik, which is a Russian vaccine. Again, it's a viral vector. Now, will the vaccine, people may ask, and there are questions, will the vaccine work against a new emerging variant? Currently, there are three new emerging variants which are in circulation. One is the UK coronavirus variant, which is, we call it Kent variant. Study has shown that Pfizer vaccine appears to protect against this variant. However, the results have not been peer reviewed. So until it is peer reviewed and published, nobody can make a statement with 100% guarantee that yes, it does. But Pfizer says it is effective. Plus, yet to be approved Novavax, they have the evidence that shows that 89% efficacy in this UK variant. Now, you must have heard about the South Africa coronavirus variant. Again, Pfizer claims that indicated that this vaccine is effective against this strain. However, these findings have not yet been peer reviewed. The Brazil coronavirus variant, technical term we call it P1, no large-scale trials or significant studies have yet emerged examining vaccine efficacy against the virus, so nobody can make any statement how effective. But in general, if we have, because they all are coronavirus, so the body's immune response will recognize the foreign body, which is the antigen coming in, within us, and will have some immune response. So the effectiveness will be there. The only chance is that efficacy may go down, but it will not be 0%. So because body will recognize the coronavirus. Now, the most important question for our discussion today, why do people from ethnic minorities suffer from COVID-19? So I have been trying to read through that. And yes, the data suggests that IFS report, it says that Black African descent was 3.5 times higher than white British people, mortality, death rate in them, while for those of Black Caribbean and Pakistani descent, death rates were 1.7 times and 2.7 times higher, respectively. So definitely the mortality in ethnic minority or a BAME community is higher. But then what are the factors behind it? So we do not have the genetic evidence to suggest anything, but there are few factors which work behind them. So I'll try to just tell you what are the factors that may have its influence. One is the occupation. So most of the BAME community, many of them who have died were in frontline roles or were key workers. So they were exposed to infection more than others, proportionately. This is just in proportion. Then some of the study also say that associated morbidities, so higher prevalence, I'm just giving you an example, higher prevalence of diabetes or chronic heart diseases in Southeast Asians and Black African and the Caribbean probably adds to complication and the mortality. That's one of the factors. Third is the demography and the lifestyle. So it has been observed, this is again the IFS study, that most of the people are living in an area with high prevalence of coronavirus, and some of its lifestyle, like a joint family living together and congested and crowded. So one member gets it in the family, then the whole household gets it. So this is one of the factors. Now, the most important, biological factor, but that we do not have any firm evidence to say that, yes, this does work. So the biological factor, they say that the BAME community have more prevalence of vitamin D deficiency. Therefore, vitamin D deficiency, which is responsible for immunity, so maybe lowered immunity, so the more chances of complications. So it may be one of the factors. Or there's one enzyme which is called ACE, acetyl converting enzyme, we call it, ACE enzyme, and expression of that enzyme affects the complications. So that disproportionate presence of this enzyme in BAME community may be one of the factors. So it is not just the genetic thing. There are so many factors behind it for higher prevalence, and then leading to complications and fatality. So these were the factors. Then okay, now, so this is, I will probably stop here and open questions if you have any.
Thank you, Anna. That was really presentation. Yeah, that was really useful here. Thank you. And it's always good to get a background and some background information on what's going on. In terms of the questions, Jamie, did we want to do the ones which were pre-asked first and then move on to the ones in the chat, or the other way about?
Yeah, we'll do the pre ones first, because some people may have similar questions, and then we'll go from there.
Okay. Did you send me a copy of those? I don't know if I had them.
Anna should have them.
Anna, have you got?
Yeah, I've got it. Yeah. So
so if you want to read out the question and then give your answer, that'd be great. Thank you.
So there was a question. And a concern the concern is raised that within our local community, that the time lag between the first dose and the second dose is 12 weeks, and will it make it ineffective, given it's no longer within the pharmaceutical company's guidelines? So answer to that, no, because the first dose remains effective for 12 weeks, and booster dose given within 12 weeks will maintain the immunity and the effectiveness. So does it help, or do you want more elaboration on it?
That sounds good to me, unless anyone wants to follow up on that at all. I think that was quite a good explanation of that. Nope, I can't see anyone's hands made. So yeah, no, that's fine. Thank you, Anna. If you want to go on to the next question. Sorry. Councillor Tony Haslam has a question regarding that. Do you want to unmute yourself, Tony?
Thank you, James. Thank you, Anna. Very good explanation. Would you have a PDF of some sort of description of that, please? If you can email it, I would be grateful, because it gives you the actually breakdown of what these viruses are for. My question to you is, what do you call it? I have obviously rheumatoid arthritis, right? And I every 4 weeks I go to hospital to get the infusion done in my arm. That suppresses my immune system. So obviously, I'm likely to get any viruses very, very quickly. I have done in the past, but thank God for that. The last 3 years, I've been having flu injections, and I've been safe so far. And my question is, this particular vaccines, do they actually interfere with the infusion I'm receiving at the moment? Obviously, I had my jab already, by the way, 3 weeks ago.
No, not. I think they have to maintain a gap between your infusion and the vaccination. That's all. Otherwise, they will not interfere. Yeah?
They never asked me, when did you have your last infusion?
They will probably not give you the appointment. So there is no direct interference. So probably there will be a gap in. So are you treated? If Emma, Miss, you can email me separately, what are you treated for, and then.
No, it's fine. I'm quite willing to share my, what do you call it, information to everyone. Maybe someone else has a similar disease to what I have, which is rheumatoid arthritis, right? It's called, or it begins a hell of a, even Boris Johnson could not pronounce the name. It begins with TZ. It came from America. They trialed it there for 10 years. In fact, and it worked, this arthritis treatment. And then they brought it here, and the doctor asked me if I would like to go into that. I thought, well, great, yes. But obviously, it's 4 weeks gaps, right? I have to have it every 4 weeks done in hospital. And they are timing to that. They give you some medication for tablets first, and half an hour later, for 1.5 hours, this infusion goes in, then half an hour for the flush. But that particular medication, the first time they'd done it for 1 hour, I came out with rash. I was itching everywhere, like if I got fleas in my body. And then I spoke to the specialist, and she said, no, we've got to extend the time. So we extended to 1.5 hours, which works finally. But the last few days, I've just got downhill. I can't move. My whole body's stiff. If I hold a pen like that, yeah, my hand will be becoming like this also. You know, but it does work. This intervene I get every 4 weeks.
Yeah, so this means what I can understand. It's an immunosuppressant drug which is given to you for the treatment, and so you are part of our clinically extremely vulnerable group, and so vaccine doesn't react with it. You know, it's the only thing. They will probably not give it to you on the same day, so they will probably maintain. Otherwise, there is no contraindication that it should not be given yet.
Thank you, Gav. Yeah, that's great. Okay, Anna, if you want to go into the next question, I'm just conscious of time. We have a lot of questions.
So the next question says, sorry, my clock.
Thank you.
Just ignore my clock, please.
Time for dinner now.
4, 5, 6, 7. Done.
The clock's quite quiet in the background if you did want to carry on.
Oh, right.
We can hear you fine. It's fine.
Yeah. So the second question is, the question was, when some people who have taken vaccination, both parties, are they able to give each other a hug? So this is one part of question. Second part of the question is, if two people have taken the vaccination, can they give each other a hug, family members, the very next day, or do they have to wait certain days for vaccination to take effect? So I'll answer in two components. One, when we have achieved required herd immunity, we have low risk of transmission, or COVID disappears from the environment, then only we can give each other a hug. At the moment, no. We still have to protect ourselves and the society. And the another answer added to that, the vaccine doesn't give you 100% protection. It reduces the rate of transmission because the viral load goes down. Even if you get the infection, our virus load. So in a summary, can you give a hug? No, still not. Yeah. Then the question is next day. Yeah. Can we give a hug next day to a family member? No. Cannot hug very next day at all. Immunity takes time to develop. The first immune response develops around 10th day of the vaccination. So until 9 days and minimum 7 days, we all are at similar risk as others who are not vaccinated. And antibodies develop in around 3 weeks' time. Yeah. So, however, this does not give 100% protection. Therefore, hug is not advisable, and if at all, then it should be from the back. Does that answer? Or any other question on that? I don't know who asked.
Yeah,
that.
we have a hand up. Like I say, if we can just make sure we keep it relevant to the question, that'd be great. Mavis, if you wanted to come in quickly, thank you.
Hello, thank you. All I wanted to know was, so if you have one type of vaccine, say you have AstraZeneca, and then the second time you go, can you have a different vaccine altogether, or you're supposed to be having the same vaccine that you had the first time?
Right. So I think this was out of this question, but I'll answer to you. You have to have at the moment same type of vaccine. You cannot mix vaccine. So if you have AstraZeneca, the first dose, your booster dose will be offered AstraZeneca only.
Oh, because they've got different efficiencies, and if you look at the stats, you'll be drawn to having a different one the second time.
I know what you are referring to. Probably you mean AstraZeneca hasn't yet published that they are effective against these variants. Yeah. But don't worry about it. They will tweak their vaccine. So the next production that comes will have the altered one. But it is advisable to have whatever you had for the first one, second one should be the similar one.
All right. Thank you.
Thank you.
Thank you. So,
okay, Anna, any
other question? Or can I move on to the third one?
No, if you move on, please, that'd be great. Thank you.
Yeah. So the third one is, on the news, it is mentioned AstraZeneca vaccination might not have protection against the, which I probably have answered, have protection against the African strain. Does it mean to be fully protected? Those who have taken AstraZeneca vaccination would now need to take one of the other vaccination, which protects people from South African variant, which I probably answered. So they haven't yet published their studies about, so my answer is, they haven't yet published their studies about its efficacy, about the variants. Therefore, we will have to wait to hear from them. And if necessary, they are in a position to tweak the future production, such as we do it with the flu vaccination. Yeah. So the fourth question is, when can we start to see those shielding being administered the vaccination? So I'm proud to say locally we are vaccinating, and we have started sending out the invite to our clinically extremely vulnerable, which are the shielding group, and they must have received the invite and are in the process of receiving. And if not, you can contact your GP. So that. Does it answer? So if I move on to the fifth question, is there any plan to prioritize BAME communities given they have been classified as high risk category? Answer to that, as I said, already have in my answer. So, but I'll tell you about the JCVI. So Joint Committee of Vaccination and Immunization prioritization is based on age, occupational risk, and chronic diseases. Because that was the priority at that time. The BAME group has not been classified separately. However, they will be receiving invitation under these eligible group. So the age, occupational risk, and chronic diseases. Majority of them will be covered under the occupational risk and the chronic diseases. But no, they have not been classified separately. So that was the question. Sixth question was, if you have sickle cell, which vaccine is best? And the similar question is, if you have thalassemia, which is the best vaccine for you? Sickle cell and thalassemia are the hemoglobinopathies or type of anemias, which is congenital, inborn error. So any vaccine is effective for any of the anemias or hemoglobinopathies. The only contraindication is if we have had severe adverse reaction to any of the vaccine, then or any other medication such as penicillin and all. Otherwise, any vaccine can be taken. Then eighth question is.
So we've got a hand up from someone, if that's okay. Sorry, Councillor Sam Lumans.
Yeah, just on the question of BAME communities being or having obviously been more deeply affected than other communities. The reasoning for it, I'm just trying to get my head around it. It's not because of anything genetic. It's because of it's circumstantial. Yeah, I just wanted to square that up. It's totally, yeah. So it's so therefore it's going to be to do with things like if you live in a certain community, you might be more likely to eat a certain type of food, which means you're more likely to pick up certain times of other ailments, which means therefore you've got underlying conditions, which means therefore that you're likely to suffer more, etc. Yeah, I thought just wanted to double check.
Yeah, so the only biological component, like I said, one of the enzyme which is found more in disproportionate presence of that ACE enzyme, which may affect. Otherwise, there's no direct genetic correlation, not yet proved.
Yeah, cool. That's what as I understood. Thank you for that. Cheers.
Again, the eighth question, I think my list is the last. Are BAME elders being prioritized due to known vulnerability to COVID? So again, as I said, JCVI prioritization does not separately include that. However, the elderly people in our county, we can very proudly say that we have vaccinated more than 90% of our 75 pluses and more than 80% of our 70 plus age group. So they will be proportionately covered within that. Yeah. So these were the questions I had. Now, what are the other questions?
Yeah, I don't know if Gilly wanted to ask. Is it Gilly? So you wanted to ask a question about one of those questions? I know your hand's up. If you want to unmute yourself, that's great. Thank you. Oh, sorry, you're still muted.
Hi. Yeah, sorry. Hi, everyone. it's a follow-up to the question that Councillor Sam Rumans asked for clarification. Is there any intention at some point in the future to identify what was the cause of the high number of COVID deaths and serious illness within the BAME community? And will it be something that looks at what type of PPE were they using at the time when they contracted it and then went on to die? Thank you.
Thank you. So probably, again, if I take your question into two components, so one of is the PPE, which probably I'm not a right person at the moment to answer that here, because still studies are going on. And the first one is, as I said, the IFS study is saying there were associated factors. So one was the occupational, and one was the associated comorbidities, one was the demography and the lifestyle, and the fourth one was the biological factors amongst them. So, so at the moment, we do not have any definite evidence to say that more prevalent or the complications were more in BAME community. Does it help? Because there were multifactorial reasoning for that.
Thank you, Anna. That's a good answer. Thank you very much.
Okay, John and Neelam have their hands up. Are these new questions or related to the questions that have already been asked, guys?
Well, thank you, James. My question is more generic in terms of which might help a lot of people.
All right, well, because we're taking them in order, if you could put it on the chat, if that's okay.
It is in the chat.
On the chat, cool. What we'll do now, we'll move on.
My chat won't go through, James.
Oh, okay. All right. Let me, yeah, I can't see yours. What we'll do then, John, I'll make a note that you've put a question, and then when we've done, we'll come to you. Okay, is that okay? Brilliant. Thank you for that, Anna. So we'll move on to the chat questions now. So I think this one's been answered actually. It's are the vaccines safe for those who have sickle cell? I think
yes, they are. Yes.
That's nice and easy. Next one. Just going down now. So a question from Titus. Why is it that people of Black and African descent in the UK are more disproportionately affected by COVID-19 rather than those back home in African countries?
Right. So I already probably, you know, of course, not in a very clear way answered it. So here, as I said, multifactorial. So one of the factor, most of the BAME community here, occupation-wise, were the frontline workers and the key workers, such as doctors, nurses, social care workforce, transport workers, and, you know, hotel industries and all those things. And they were more exposed to the infection than others. That's one of the factor, but I may not be answer everything here at the moment. Yeah.
So it's more lifestyle related, isn't it? Thank you. A question from Councillor Callie, who I believe is not with us at the moment, but we'll pass it on to her. What are you doing to ensure the vaccine is safe to everyone within the BAME community? Also, she is very concerned about the misinformation that is being pumped out down social media regarding the vaccine.
So, so we do have a communication plan, isn't it? The COVID campaign, and there's a for me as a public health physician, I have my equality impact assessment where we are doing a targeted work and targeting BAME community and being a health protection lead, I have been working with all other immunizations. So we know the community who are reluctant to receive vaccinations, not just COVID, any other. So we are trying to work with them and trying to influence, but we would need support from our community leaders and all other BAME associations working within the county to help us promote our messages and reinforce and influence them and try to, you know, just the myth which they are living with, try to influence them to break that, yeah.
Does that include things like leaflets in different languages as well?
We do have some of it, yes, and we can share it, yes. Yeah.
Excellent, thank you. A question from Neelam. A lot of people in the BAME community have underlying health conditions and are likely to be on medication or injections. Did you want to expand on that, Neelam, at all? what you're asking?
Yes, James, and I think the second part of the question is typed after another question. So what people really need, Anna, to understand, and this is an important message, that there is no clash between the vaccine and these underlying health conditions and the medications people might be on. That's what people really anxiously waiting to hear, that reassurance.
Okay, all right, okay. So I'll take it back and I'll just report it to my communication team, the countywide, that this is what is required. The only thing which is required is a 7-day gap between a flu vaccination and the COVID vaccination. So we are not giving it together. So we are just trying to maintain, just to see, because we don't know which vaccine side effects are there. So just to observe, it is contraindicated. So if somebody gets side effect because of the flu or the COVID, we will not be able to know which is the reason, what is the reason behind it. So that's why. Otherwise, there's no contraindication. But I'll take it back. Thank you very much for letting us know. Very helpful.
Thank you, Neelam. So we've got a few questions from Mr. Atwell. So firstly, due to the BAME community being impacted more than others, are both vaccines suitable for members of the BAME community, or is one more effective than the other?
So the effectiveness of the vaccine is irrespective of the ethnicity. It is the person. So effectiveness varies. So, but it is around 90% for Pfizer and AstraZeneca both, and Moderna has around 94 to 95%. But the effectiveness and the efficacy doesn't depend on the ethnicity.
That's irrelevant. Brilliant. The second part question is: can you choose which vaccine you want to have, or is there no choice in this?
At the moment, no. So the people healthcare workers like us who were vaccinated in the hospitals. So the hospitals, because Pfizer vaccine required maintaining, the temperature of minus 70 and all. So most of the healthcare workers who were vaccinated in the hospital hubs were offered Pfizer and initially, and then now at the moment, it all depends on the supply of the vaccine.
I see. Thank you.
Because they are equally effective, so it doesn't make a difference which one we receive.
Brilliant. And then the final question from Mr. Atwell, what's the message for people in the community who say due to the media, they will wait for later in the year when an updated vaccine is released? I mean, you've sort of covered that in terms of comms, but I don't know if you want to expand at all on that.
Sorry, my point there is just around in the media, they're talking about, new versions of the vaccine coming out later on in the year. As we learn more about the different strains that are coming out. And that might lead to people saying, well, I don't want to be a guinea pig for the first round of vaccines. I'll wait until an updated version of the vaccine comes out and I'll take it later on in the year.
Right. Oh, that's a good question. Yeah, so we'll have to do something, but like Pfizer and so naturally the government will not start vaccinating people until it is regulated by or approved by the MHRA. And Novavax or the Moderna, we are not receiving it until, but I take your question. We'll probably have to work and inform community that they all are equally effective and they are well regulated. So any vaccine you are offered is equally beneficial. So I take that question and we'll try to work around it.
Brilliant, thank you. A question from Councillor Pinder Chachin. Can individuals with allergies still have the vaccine? And the other concern I have is that, I've been approached with women who are pregnant, and are they allowed to take the vaccine? So pregnant women, are they safe to take it?
So yeah, so the pregnant women, the AstraZeneca and Pfizer, the studies, we are not offering it to pregnant women because we do not have adequate data to support their safety in the pregnant women. However, the pregnant women are not contraindicated. The government had decided the pregnant women who are clinically vulnerable or with other associated morbidities where there is a risk of mortality or complications can be vaccinated, but not in mass because we do not have adequate data. Okay. Does it help?
Is that all right? Brilliant. Okay, a question from Neil Goosey. Is there empirical evidence to support the view that BAME communities have to have a lower uptake in the country or county, I believe, actually? Evidence taken.
So because the ethnicity was not recorded, so we are recording, and we'll be able to provide some data later on. So in the county, we are recording ethnicity. So once we collate the information, but at the moment, probably whatever we are saying is whatever is available from the national sources, that the uptake is, there is a reluctance by the BAME community. And that reluctance is not just because of the COVID. It is, so reluctance is for MMR as well, reluctance is for other vaccines as well. So the vaccine reluctant groups are there. But for COVID specifically, I'm not in a position at the moment to give you the exact figure.
But we know nationally, don't we, that is the case. So yeah, one would assume it's the same here. I don't know if that's a question from Councillor Aslam. It's just you're commenting on the videos there. That's fine. They're being made, which is great. A question from John Rawlings. What measures have been taken to encourage BAME groups to take up the vaccine, especially those who live in close communities, i.e. shared housing, that sort of thing? I mean, again, you might have covered that somewhat, but if you want to expand on that at all, Anna.
So our communication plan, so like we are trying to work with the organization. So we have a plan. So at the moment, if I exactly don't remember our communication plan, but we'll be working with the Gurdwaras and the NBA, which is a Northamptonshire Bengali Association. And so at the moment, 2 of it I know, but we'll be working with our community resilience group to reach out to them. And the communication team are working. So I can share the communication plan, our targeted plan with you all, which will probably have the detailed update on it.
Excellent, that's great. And then the final question in the chat, and then we'll move it to the floor. Do you know, just from Neelam side, do we know the percentage of BAME members who are refusing? In fact, that question you've sort of already answered, don't you? That we don't have the county data yet.
No, yeah.
No, okay. Brilliant. Okay, so John, was your question answered okay? Were you happy with that answer?
Yes, but I was in a meeting on the board of Northamptonshire Health Watch, and we knew this was coming up today, and we do look to this committee to actually, have a big impact on the BAME community. What I also noticed, and I do it every time I come to these meetings, is the East Europeans tend to live very closely together, especially young men, and we do not seem to have the contact. It was a wonderful array of Asian and African colleagues that come regularly to these meetings, but we seem to have no contact. And I don't know what statistics are. Are there statistics, Anna, on the East Europeans?
So we are, just because I have been working with them for the flu vaccination, because and trying to reach out to them across the county. So we are using those. I do not have the COVID statistics, how many vaccinated and not, but the flu we do have, and using our flu data, we are trying to reach out to Eastern European community across the county, and providing that information to our GPs and the PCNs, that this is the reluctance, this is the area where you have reluctant group, and can you please identify and just invite them. So so this is how we are working. We are working with Somalian population as well, who have a big resistance for vaccines. So it's not just COVID, the other vaccination, MMR and flu vaccination and all those things. So we are working with them as well. So some of the rough sleeping population, which involves a lot of them. So we are vaccinating all our, so I have written a proposal, unfortunately have been accepted. So we'll be offering vaccination to all our homeless communities and who are in temporary shelters, plus rough sleepers, street sleepers. So that covers part of Eastern European as well.
Thank you.
Yeah.
Okay. So Gilly, did you have your hand up? Another question, Gilly?
This is the question. Sorry. This is a question for Anna and Vicky. This is an excellent presentation. Thank you all. Are you going to arrange for the slides and information to go out to GPs, secondary schools, FE colleges, and the University of Northampton, because they can be part of the positive vaccine messaging, because they'll talk to each other, but they'll also talk to their families as well. And the issue about the Eastern European community is actually quite interesting, because we have had an established Polish community. I went to school with children from Poland, and I think if you can reach out to the Catholic Church community, quite a lot of the Eastern European community, they come from the Catholic faith. So if there's a way that they can be involved in terms of promoting it, and also the Polish community in Northampton has got a lot of links across the Eastern European communities. But thank you for all this.
Thank you. I take your advice, and I'll just approach them. But we will be working with churches, and we are working with churches. So probably if I come to know which is the specific one where they are attending and all, that would be helpful.
Brilliant. Thank you, Hannah. Neelam, did you had your hand up? Did you want to ask a question?
No, the hand is still staying up, James, from previous.
Okay, I thought it might be. Pinder, wants to come in.
James, thank you. Thank you, doctors. This has been a very, very helpful session, actually. It was just a supplementary question to the one that I asked previously, and it wasn't answered. It was just to find out about the allergies and whether the vaccine is okay for people with allergies to have as well.
Okay, to answer that, so if somebody had a severe anaphylaxis or a severe adverse reaction to any medications or any vaccine and all, that's not a contraindication. They will have to inform. So then the clinician will decide either can be vaccinated. So the weightage then can be vaccinated under supervision. But our responsibility is, like, I have severe allergies and I also had anaphylaxis. So I had to go and tell them. Then I was vaccinated under supervision. So there's no, and other than anaphylaxis reaction, there is no contraindication. We just have to inform them that I have had this allergy, and they will then observe us and vaccinate under supervision.
Brilliant. Thank you.
And it looks like the final question from Councillor Aslam. If you want to come in, Tony.
Thank you, James. I just want to go back to the point I think my good friend Neelam raised in regards to the stats on VME community. I was in the COVID, I get regular, we attend every 2 weeks COVID updates from the Northamptonshire County Council, Unitary Council, sorry. And I always raise this question. They are planning to come out with the stats because I've raised the issue for that. And the other thing I was going to say that I have up-to-date information came through today from today's presentation. I don't know if anyone was there at the meeting today this morning, 8:30. If not, if you'd like to give me the email address, I can forward that presentation to all of you to share that, the whole of the stats for Northamptonshire County, if you like.
Thank you, Councillor Aslam. Yeah,
and if I may add to that, we are collating that information. So every vaccination, so modeling team, they are asking to complete the ethnicity. So when we are booking in and they ask us our ethnicity and all, so I think we will soon have the data.
And also there are videos made by various different languages. I mean, I made one a few days ago, it came out today now, in Urdu and Punjabi and English mix, all that, to encourage our community to come forward to have this vaccine done. It is safe and one of the best things you'll ever have, because obviously I'm sharing my thoughts, what I've had the injection done already, so I'm sharing that with the community right across the county.
Brilliant. Okay, I think that's the end of our questions. I can't see any more hands up. I'd like to thank everyone for attending tonight. I think it's been a really useful session, really informative, and a special thanks to Dr. Sen. You've been fantastic tonight. I think we'll all agree that you've given really good answers to all the questions. Basically, as we mentioned earlier, the meeting's been recorded. So in terms of how people get hold of that, Jamie and Vicky, what